Good morning, everyone. And we often start our meetings with start on a positive. And there's two things that I've heard this morning. One is the positive feeling about the impact this 20-week program has had and the insights it's generated. But the other thing that really I find very positive is the language which is being used in the room, which is how, and yes, we can do this. And that's an amazingly positive use of language. And if you think about that, there is a can do. It's not going to be easy, but there's a real can do. And over the last 20 weeks, there's been that beginning of the journey. This is a massive change, as I'll go on to illustrate, in the way health and care operates. And I'm choosing my words very carefully. Yes, it is about the NHS, but it's about more than the NHS. It's about creating a movement. It's about creating capability. Actually, I'm not sure it's about creating capability. It's about unleashing the capability you have already in your system. Unleashing the potential of the system. It's about, one of the light bulb moments for me is understanding that this is about taking a whole new lens to look at the system through, which is the perspective of what's happening to individuals. And there is this both and. There is a need to unleash the potential on the front line, in the neighbourhoods, and I will say this and I'll repeat it endlessly, is that my belief is that the neighbourhoods are going to be the engine house of transformation to deliver population health management and better population health. And everything should be geared to supporting that. But, there is a common purpose. And what we need to do is to be able to honour the motivation, the engagement, and the involvement of the frontline teams and we have some national priorities. We have some big problems. So how can the neighbourhoods help the system manage those big problems? And that's the next step. That's building confidence and trust in building confidence in the neighbourhoods that they can do things differently, that they have the permission from the system leadership, that they are enabled by the system leadership to do something different. But in any give, there's always an ask. So how do we also support addressing the big problems? And it's a both and, it's not an either or. And that's a new way of working in the NHS and in the health and care system. This is ultimately, and what I've found really enjoyed going and meeting with localities and listening to, as you will do later on, is what does this mean for people? Because at the end of the day, it doesn't matter what we do if it doesn't change what happens for individuals, for people. I've always said this, I've said this before and I'll keep saying it. This is a human endeavour built on human values, delivered by human beings for human beings. It's not a technocratic, esoteric, strategic exercise. At the end of the day, there are real people with dis-ease, with worries, with concerns, with fears that everyone in this room helps. And you're big. If I'm honest, when I first looked at what we were being asked to do here, I thought, no way. And I'm incredibly proud to be party to what you have achieved over the last 20 weeks. People have already mentioned, how can you unleash the assets you've got at the moment in the system and use them in a more purposeful manner? How can you see what needs to be done through a new lens? how can you harness the potential of your frontline teams? As Chris Ham said 30 years ago, the people who commit resources are not the chief execs. They're not the directors. They're the GP who prescribes. It's the nurse or the OT or the physio. It's the care coordinator. It's the social worker who truly commit resources. And unless they see how they can do that in the best possible way, then no wonder the system gets into trouble. So how do you align to the motivation and the commitment that people on the front line have? And how does everyone line up behind that? Modern medicine, if any of you haven't read, and you should have because I've mentioned it before, Atul Gawande's article, which is free on the net, called The Cowboy and the Pit Crew. And the way I was trained in the 20th century was to be the heroic individual who saved people's lives, striding across the plains, ravaged plains of disease in the far west. Modern medicine, modern care, is more like a Formula One pit crew. It's a team effort. No one person can do it all. So how do we harness the fantastic potential teams we have on the front line? And people in this room have started to show how to do that. How do you bring into that team the analytic insight linked to the human intelligence to really power up the right interventions for people in your local communities that address the whole human being, not just a biomedical model? And we've used this slide for a long time to talk about population health management. But actually, my insight from working with you and others over the last year, and especially over the last 20 weeks, is we should be using this slide. Because it starts with the person. It doesn't start with the system. We look at the whole system through the individual and what's happening to them. We build that up into cohorts, into groups, into neighborhoods, and we understand the variation, the difference, what's going on, what has meaning in that local community, because it's a complex system. And then at place, we can build up that segmentation, that benchmarking, that understanding, and finally, the system, using its economic modelling and actuarial projections, can support the right, as people have been saying already, asking for today, the right resource allocation between providers, within providers, design the system based on what the frontline teams are seeing is needed, is required. It no longer becomes about individual organisations or individual conditions. It becomes person-centred. And that, to me, is one of the most thrilling things about this. And I was recently, last week, speaking in a conference with one of my colleagues from Optum, Dr. Ken Cohen, who's the chief exec and chief medical officer for New West Physicians in Colorado. I'm desperate to organise a study tour. But he was saying how New West Physicians have completely transformed their operating model and their approach to care. And as he spoke, I started writing down all the things he was doing that the NHS wants to do. Right care, PCNs, getting it right first time, shared decision making, care coordination, transitions of care, care homes, A&E diversion, access, too much medicine. And then on the other side of the page, I wrote 4 things which I thought he had got and you're on the brink of delivering. Because these 4 things unify your ability to deliver all of that as business as usual, not as little initiatives or separate pilots. A single source of truth. One data set for the system. aligned incentives. You have a single, Jackie told you, you've got a single control total. There is one budget, one amount of money per patient per year for Lancashire and Cumbria. Clinical leadership, really important because, as I say, the people who commit the resources are on the front line. And finally, perhaps slightly controversially in the NHS because of our history, and this was a physician, a specialist. He said, this can only be delivered if it is primary care driven. And for me, one of the points I'd like to land with you is that population health management cannot be delivered without PCNs, neighbourhoods. And neighbourhoods don't really have a purpose, in my view, unless they're delivering population health management. So there's a symbiosis and a great opportunity in the NHS now for this in Lancashire and Cumbria. The objectives of the programme were to create a system, an integrated care partnership level model, and we'll come on to that in a second. Support neighbourhoods in targeting cohorts. Transfer skills and capabilities inside and unleash the potential locally. Sort out the IG, as has already been, but then also there's something about sustaining, not just analytics capability, but change in the system. And that's where we're going to be working with you. You have to design what is needed. And I like the point that was made earlier on about asking questions of the system leaders. How are they going to help you do what you know needs to be done? So if we go a mile wide and an inch deep, it's a massive area. And that's what where we kind of started. 37,000 social care packages, just to run to the bottom of that. So we've done, this is a sample, we're doing an actuarial analysis, so projecting, based on historical data and trends, what's going to happen to your system over the next 5 years if you do nothing, if you carry on with business as usual. And it's bust. The demographic changes, inflation, case mix changes, advances in treatment and technology just carry on growing. But modelling how doing things differently shows you how you could mitigate that. You can't stop it. There will be an increase in growth in the system, in resource utilisation, but you can change it by the appeal, which I've heard made today in this thing, is we need to move beyond just a pure acute hospital being the main focus of what happens in the system. And this kind of shows you the depth of the problem that's happening at the moment, an illustrated theograph. And the theographs show the acute activity, non-elective, outpatients. You've got A&E attendances just for one patient. And when we link this up as areas, I think there's an example of this later on, with all the community mental health and general practice data, you suddenly get a comprehensive view of the system. And I liken a theograph to an ECG of the system, as I've said before. It shows you whether the system is in sinus rhythm or not. I've seen no evidence that the NHS, in fact, is in sinus rhythm. So we do have a fairly significant problem to address. But what we've done, and this is really interesting for me, is go just an inch wide, but a mile deep, with colleagues in Barrow, in Blackpool, in Chorley, in Burnley, and in Skelmersdale. And that has taught, I think, us a lot. We've learnt alongside you. But also, do be aware that, and I think Jackie sort of echoed this, it's taught NHS Central a lot as well. They've been really interested in what's happening, how this is getting traction, sensing the motivation of the frontline teams to do things differently, and the willingness and appetite to do that, informed by and supported by, but not dictated to, by the information and analytics, and honouring the additional. Now, I think is it Skelmersdale assisted? assisted bin collection. Who was it? Or Chorley? Chorley, sorry. Oh, they could. Yeah. Don't worry. Just to let you know, Berkshire have already taken it. But what brilliant to bring in to say, okay, let's add to our data and insight assisted bin collections so we can identify better the people at risk, because there's additional data we can bring because of our local knowledge and intelligence about what's happening in the system. That's where unleashing the potential of the frontline staff to amplify and accelerate this work is so important. Looking at the areas, I mean, it's quite interesting, isn't it? Mental health, depression, frailty, and respiratory. Some of the big pressure areas that Amanda's got to go off and talk to the BBC about. But how can we also, one of the things I want you to think about in the roadmap is, how can we link this movement, this work on the front line, to the big challenges that the system faces? Because if we ignore those, then this will not get the traction and ownership it deserves. So there's a both and here, and I want you to keep that in mind as we're tackling the way forward through the rest of the day. So I'm going to stop there.